Hello and welcome to this training video on working with individuals with a history of abuse. I'm Mark Brennan. I'm Project Director of Community Support Training at the Missouri Institute of Mental Health Continuing Education Division in St. Louis, Missouri. And with me today is Dr. Angela Mechikoff, who has a PhD in psychology. She works as a clinical psych intern in multiple inpatient psychiatric facilities. She has been involved in research, various and sundry kinds, and mostly with abuse, and also has been involved with a women's abuse shelter. Hi, Angela. Thanks for coming today.
Thank you.
We're very interested in this concept of abuse and assessments, and as a professional who's worked in psychiatric facilities, inpatient and outpatient, it would be really helpful for you to help us to understand some of the issues surrounding abuse with psychiatric disorders. So first of all, I guess I'd like to know, how likely is it that clients receiving mental health services have a history of some form of abuse?
There isn't really a consensus on that. There have been a lot of studies done, particularly in the last few years, trying to get some kind of a number with respect to the prevalence rates. What we're seeing is anywhere from about 30% to 70% of clients or patients that are being seen for mental health services as having some kind of abuse, whether that be physical, sexual, or neglect. Women's rates tend to be higher than rates for men, but we're seeing higher and higher rates for men over the years. Whether that's a factor of, we're asking more often, we're assessing maybe more appropriately, or people are feeling more comfortable with disclosing those histories, we're not sure. But I would say right now it's fairly reliable that we're at least looking at 30 to 50% of our patients having some kind of a history.
Well, that's a kind of a high percentage.
It is high. And along with that, what we're seeing is that oftentimes in studies there's about a 30% rate of not knowing. In other words, either it wasn't assessed or the information wasn't available, but there's about 1/3 of patients in a lot of studies where we simply don't know whether they did or not, so those rates are estimated to be a lot higher.
So what kinds of problems that people who have been abused, what kinds of problems do they have?
Well, one of the key problems that we're seeing for people that enter mental health settings is poor outcome. People that come in that have those abuse histories tend to have a much more chronic course of their illness. They tend to be in the hospital or outpatient clinics much longer. Their symptoms are much more severe, and we see even things like the return to a hospital setting, people that are having multiple admissions in a given year, as being part of that having a history of abuse. Multiple problems. You're hearing a lot about dual diagnosis programs, programs that are designed to treat people that have substance abuse problems and mental health problems. There is a very high percentage of patients that have abuse histories that are in those programs. In other words, patients with abuse histories tend to have not only major mental illness, but will have substance abuse and other problems of living.
Nice. So if I understood you correctly, it sounds as if people who have both a mental illness and abuse history tend to go into the hospital more frequently, and their length of stay is longer than those who only have one or the other.
Right, and that can be a factor of 4 times. I mean, there are some studies looking, at depression, for instance, women with depression without abuse histories versus with abuse histories, and seeing that there's a 4 times greater likelihood if you haven't had an abuse history of recovering within a year. Whereas people with abuse histories, you might be looking at an average course of 15 years of symptoms.
So how is that different than people who receive mental health services who don't have a history of abuse?
Well, it's different not only, and again, we're looking at the people that actually are in the mental health facilities. There are a whole bunch of people that we know, at least in looking at base rates, of individuals who just have experienced, history, but don't end up in inpatient or outpatient settings. that are there and having all kinds of problems. But for those people that are in inpatient and outpatient settings that seek mental health services, not only are there problems with, again, length of stay and treatment, but there's also the concern about re-victimization. And just by not treating them with respect to the abuse histories or the abuse that they've suffered, that actually makes them even more symptomatic in a lot of respects. So, I mean, I think that centers up to this point just have not been ready to address the impact that trauma has had on people, and particularly with respect to their mental health.
I would imagine also from a historical perspective, if facilities haven't really given much thought to the importance of abuse, there probably haven't been screening for that abuse.
Right.
And so I guess one of the questions that comes from that is, what is the typical screening process like?
Well, and that varies by setting as well. And again, there isn't really a consensus on that. One of the problems that we face, and particularly with respect to the treatment of people in outpatient and inpatient, is the traditional models of care were more based on a biological model. And certainly we know, for instance, with schizophrenia, with that particular mental disorder, that there is a biological basis to the expression of that disorder, and we treat it, on that basis. But there's been a lot of controversy about whether even traumatic abuse is an important factor, and there are a lot of programs that are more traditional that still don't consider that an important factor. And so from those programs, abuse might not even, or abuse history might not even be assessed. And if it is, it might be a checklist. Were you abused? Were you not abused?
So it doesn't really help me to process the information. I would just be giving you the information.
Right.
Is basically what you're saying.
Absolutely. And so if you look at that process, first of all, I say to you, have you been abused? I'm labeling you, first of all, and then I'm pushing you into a situation where you have to decide if you're going to accept that label. If you're acutely symptomatic, you might not know. One of the things that we know about people who have traumatic abuse histories and who suffer from what we call post-traumatic stress disorder is that they tend to use dissociation as a major coping mechanism. And when I say dissociation, that means to pull away from or push away memories of events that were traumatic, to dissociate, as the word is stated. So you might be asked that, and if you are able to dissociate, you might not remember, or may have that so far out of your awareness that it's not called into consciousness. And again, you might be acutely symptomatic or have some delusional symptoms that don't allow you to answer that question. And so the check box is marked no.
In terms of assessing, I've thought of issues and situations that have come up in assessment and thinking about domains or areas to assess in. Usually in an inpatient setting, there's some kind of formalized process like a psychiatric history, a social history. And if I understand what you're saying, more now than in the past, people are aware that abuse might be another domain to assess for.
Absolutely. And I can speak to you from my experiences, at least most recently in inpatient settings, where that is part of what we call a psychosocial assessment. Usually patients or clients entering a facility then will be screened on a variety of different domains. Certainly there are the physical aspects, there are mental status components. Are they oriented to person, place, and time? Do they know who they are? And then, of course, a history, which would involve everything from educational to vocational, and history of abuse. Okay. And so those questions are asked as part of the screening.
In addition to the assessment piece, there are obvious implications for mental health service delivery. Can you talk to us about the types of approaches that are recommended for treatment?
Yeah. Again, you know, going back in time, there was more of a focus on the biological basis of mental illness, particularly in inpatient care facilities, and less so in outpatient treatment programs. But medication is of course, one of the main forms of treatment that occurs, you know, within an inpatient setting. But there wasn't much of a focus or emphasis on traumatic abuse as a particular facet of one's mental illness in terms of treatment. And so while it might have been taken into consideration, it certainly wasn't the focus of treatment. Patients entering would be treated on the basis of their symptoms, whatever symptoms were being displayed at that particular time. And people who are symptomatic, who have had abuse histories, who appear to have the same symptoms as someone who doesn't, would be treated similarly. Again, however, some of the symptoms that are being presented, let's say self-mutilation, which is a common symptom or facet of a history that you might see in someone who has had abuse in their past.
That would be like cutting or burning or harming one's own self.
Right, exactly. Even bulimia is considered a form of self-harm, engaging in high-risk behaviors. That serves a function for a person who's been abused. That might be the difference between saving themselves or not. It might have arisen from guilt or blame that they feel in having been abused and feeling responsible for that abuse. You know, so helping that person to reframe those behaviors in terms of it being adaptive, in terms of it being a way to cope, is very different from someone who demonstrates those behaviors that hasn't had abuse history or abuse history.
So these are some of the behaviors I might see if I was working in an inpatient facility, that I might find uncomfortable and confusing, but somehow I have to work that into the relationship that I have with the individual. So I can't just ignore those behaviors. Well, let's just say I'm working in an inpatient facility and it goes beyond the behaviors that the person wants to talk with me about their abuse. How should I respond?
And what we're talking about is a sensitivity then to that patient or client. Keeping in mind that what we're trying to do now is to take a look at how can we empower people in a system where they generally don't have a lot of power. The reason, and that speaks to the kind of communications that you need to have and the sensitivity that you need to have in working with or approaching patients that have this history. If you look at abuse dynamics where a person has been, you know, who is powerless, can't stop the abuse, can't control the abuse, maybe they're being violated physically or sexually, and so as a consequence of that, they're self-mutilating, maybe using substances, because that's the one bit of control that they have. So understanding that will help you in order to reframe your way of thinking about a patient or client and your interactions with a patient or client in terms of their behaviors. So for instance, let's say that, as you said, a client approaches you and wants to talk about their abuse history. Again, you don't want to label. You don't want to say, oh, so you've been, you know, you're an abused person, you know, rather just being open to the discussion of abuse, even if they might approach you and then they might pull away from it, or they don't approach you but they're behaving in a way that makes it likely that you think that they have been abused. Even opening the door to that and describing the behaviors and how it might be functional for them is important.
Would it also be important to stress safety as an issue, that the person who's talking with me is in a safe environment? As I imagine that people who have been abused probably have trust and safety issues.
Right, absolutely. And again, that goes back to giving people choices, because if you think about it, let's take an inpatient facility. A patient comes in and is given medication against their will, maybe restrained when they've acted out, maybe they self-mutilate, and our response to that is to sedate them or restrain them, okay? Again, no power, no choices, being punished for doing something that might be soothing or comforting. And if a patient complains about medication or complains about their treatment, we're considering them a difficult or resistant patient.
You know, that really strikes a chord with me. I've been involved in situations in units where there tends to be a groupthink regarding individuals who might be demonstrating hard to handle behaviors, and things happen where people will say, well, he's just manipulating or malingering, and I imagine this is what you're trying to get at in terms of being supportive in both the behavior and the verbalizations, and not coming to conclusions necessarily.
Absolutely. So someone says, going back to your earlier question, I've been abused. How do you respond to that? Well, you might say, tell me about that. What does that mean for you? And being open and being non-judgmental instead of saying, oh, you're trying to use that as an excuse? You know, you just did such and such, and, you know, you need to be responsible for that, you know. So instead of blaming, shaming, making them keep that a secret, you know, those kinds of things. You're right. It's all about valuing the client, patient, and their experiences as being real.
This speaks to the sensitivity issues in inpatient facilities regarding dealing with folks who have had abuse histories, that these issues, the issue of respect for the individual's experience, allowing them to dictate maybe the parameters of what they want to talk about. Those are issues that I would need to be sensitive to.
Absolutely, absolutely.
Can you tell us about team involvement or team process, and how that team process might help individual treatment?
Yeah, again, I think that the team process is probably critical in the sense that, as you pointed out, trust being an important component, it's likely that a client, for one reason or another, a patient, forms one kind of relationship with someone on the team that's very different from someone else. Again, we don't know. There may be cues or triggers, things from the past that even the patient or client isn't consciously aware of that make them feel safe with one person and not another, you know. And so given that you have an individual who at any given time might have different relationships with different people, it's important that everybody that's participating in the care of that patient or client can coordinate what's going on for that patient or client. Again, let's say that an aide, for instance, escorts the client you know, to the TV room or the cafe or something, and an incident occurs. It's going to be important for the team, who each have different pieces of information perhaps about that client, to process that. Maybe the client is a female and a male escorted her, and this was 2 days after admission, and no one asked her whether she had a preference. You know, maybe, you know, she's a rape victim who just came in, and you know, the perpetrator was someone that looked just like an aide. You know, there are all kinds of different reasons that certain things can happen, and putting that all on the client or the patient, and you know, making that a manifestation of their illness isn't appropriate all the time. So that's, I guess, the value I think that a team has, is that you have different people involved in different facets of the care, and that needs to be coordinated. And again, reframed in the context of the impact that those abuse experiences have on the person today.
In summing up some of the information we've talked about, can you talk to us briefly about what kind of system-wide changes can we expect in the treatment of individuals with abuse histories? Yeah,
I think you're going to see, and we're seeing this, you know, in the last 5 to 10 years, there are legal changes that are occurring. Certainly there are committees being formed at the various state and local levels to analyze exactly how we can address the problems that we're seeing. I think with the cost of managed care and the cuts that we're starting to see with respect to care, we need to be able to demonstrate that our programs are as effective as they can be. Certainly seeing people who have a 15-year history who have spent $3 million in their care and not improving is not a good thing, not for the person and not for the system. So I think that you're going to see outcome-based outcome-based treatments that directly target the traumatic abuse and fit that into the treatment protocol. Rape crisis centers are springing up. You're going to see units and wards particularly designed for people with PTSD, or traumatic abuse, and I think that will move into the inpatient and outpatient facilities in the next few years.
So it sounds like that will improve accountability not only from a system perspective, but from the micro perspective of treatment strategies for folks who carry a diagnosis of mental illness as well as have abuse histories.
Right.
This has been such an important and interesting topic. I thank you for coming in today and sharing your information with us. I would encourage everyone out there that with reviewing the key concepts as well as reviewing the glossary of terms, you're going to be able to take the test no problem. Thank you for your time.